next presenter is Dr. Himani Gupta. She'll be talking on functional MRI and OCT angiography changes, pre and post occlusion therapy in anisometropic amblyopia. Similar kind.
So good afternoon all. I'll be presenting on anisometropic amblyopia, the functional MRI of the brain and OCT angiography of retinal vessels, pre and post occlusion therapy. So currently occlusion therapy is the mainstay. However, 15 to 50% fail to respond to this therapy, and none of the studies have evaluated the effect of occlusion therapy on cortical changes. Hence, the neural basis of response to the occlusion therapy is unknown. So our main objective is to identify baseline neural connectivity markers which can predict the response to occlusion therapy and to evaluate post-therapy changes in the cortical activation on functional MRI and white matter enhancement on diffusion tension imaging. After assessing baseline visual acuity and contrast sensitivity of 30 anisometropic amblyopia patients, we perform OCT angiography, resting state functional MRI and diffusion tension imaging. Following which, 6 hours per day of occlusion therapy was prescribed on the better eye, and 2, 4, and 6 months of follow-ups were done. Resting state functional MRI and DTI was repeated only at the end of 6 months. We included 5 to 15 years of treatment-naive anisometropic amblyopia patients and excluded other causes of amblyopia. Based on visual acuity improvement at 6 months, we divided the cases into responders and non-responders, response being more than 2 lines or 10 letters of improvement in ETDRS logMAR visual acuity chart. Interestingly, we did not find any significant differences in age group, gender, refractive error, and density of amblyopia in between these two groups. We went back and studied baseline resting state functional MRI, and we found significant differences at the cortical level. So the regional homogeneity in the cluster of cortical networks was seen in responders and heterogeneity in non-responders. If you can appreciate, a single cluster of cortical network is solely dedicated to a single named cortical network in responders. For example, we have a separate cluster for visual network, saliency network, language network, and frontoparietal. This we refer as regional homogeneity in the cluster of cortical network. Whereas in non-responders, we found a single network cluster has more than one different named cortical networks. For example, default mode network, language network, and frontoparietal network, all these are clustered together in a single cluster. This we refer as regional heterogeneity in the cluster of cortical network. Following occlusion therapy, we saw the correlations among these cortical networks, and for the further analysis, we'll be referring red and yellow colors, that is warmer color for the positive correlations and blue colors for the negative correlation. So in responders at baseline, you can see some blue areas, that is negative correlation, which are affecting the visual functions negatively, is replaced by yellow and red areas following occlusion therapy. So there is significant increase in the positive correlations following occlusion therapy in responders. Whereas in non-responders, you can appreciate the significant increase in negative correlations, that is blue areas, following occlusion therapy. On analyzing the visual metrics, you can appreciate more defined and larger visual functional areas in responders, whereas it is shrunken in non-responders, and it is negatively influenced by extravisual cortical networks. You can also appreciate well-organized visual network in responders, whereas it is disorganized in non-responders. On analyzing the connectometry, that is the white matter enhancement pattern, we found that the superior longitudinal fasciculus is more enhanced in responders and corpus callosum is more enhanced in non-responders. So this respective white matter tracks connects inter and intrahemispheric cortical network, which further enhances the positive and negative correlations with the visual functional areas. And so, the selective functional changes in the cortical connectivity and the selective structural enhancement in the white matter tracks are complementary, producing the variable responses following occlusion therapy. We also studied OCT angiography, in which in our study we did not find any significant differences in the vessel density and perfusion density of superficial capillary plexus on macular OCT angiography and ONH perfusion on ONH angiography, probably because of the high intersession variability even in the fellow eyes and in the control eyes in our cohort. So I would say that this was the beginning of a scientific exploration which for the first time highlighted the neural connectivity marker, that is the regional homogeneity in the cluster of cortical network, which is predictive of better response to the occlusion therapy. And we found the various cortical connections which is responsible for positive response in the responders following occlusion therapy. And we found the cortical connections and white matter tract enhancement pattern which is responsible for the no response following the occlusion therapy. Thank you.
Very nice presentation. Only thing is, like, when you're seeing the homogeneity and it is increasing as you're saying, it is a subjective matter. It is subjective matter. Got it?
No, ma'am.
Like interpretation will vary from person to person.
Ma'am, actually it is done in the software. So the analysis what we have got is not done by radiologist or the ophthalmologist. It is done by a software. So it is objective analysis.
Then it is very nice.
Yes,
Very good presentation.
Thank you, ma'am.
It would have been again better if OCT-A and MRI, functional MRI results could be compared in the same group.
Yes, ma'am.
Because you have studied both.
Yes, ma'am.
You have that set of patients.
Yes,
You
ma'am.
can compare both to see, like we knew from the past paper that OCT-A has an influence.
Yes, ma'am. We have saw that, but in our case, there was high like intersession variability. Even the morning and evening parameters were different in the same patient in the intersession. So, like we were not able to comment on the
Which intercession in which in
OCT angiography pattern.
so was it performed by one person? The technician who does it.
Ma'am, I myself perform the.
In all patients?
Yes, ma'am. So, like our main focus was on the functional MRI and to actually we want to look after the potential cortical network which is there in the non-respondent, and so that we can find the visual stimulus which can stimulate those areas in the cortex, so that we find some treatment modality for those non-responders, and then we can recommend some patients undergoing the fMRI to predict whether they will respond or not. So our main objective is to focus ultimately on the treatment of the patient. So we wanted to look the potential network which are like differences in both the group
So
of patients.
how frequently you do the MRI?
In our patient, ma'am, we did after 6 months of patching therapy.
6 months of patching followed by MRI.
Baseline and following therapy.
So you are following new modalities for amblyopia therapy. You are following new modalities.
Ma'am, actually we have started dioptics also to those patients who are non-responder. So the study is ongoing.
Okay. And have you tried Banox also?
No, ma'am.
That's also good modality. You can try it.
Yes, ma'am. Thank you.